Congenital adrenal hyperplasia, or CAH, encompasses a group of autosomal recessive disorders, each of which involves a deficiency of an enzyme involved in the synthesis of cortisol, aldosterone, or both. The diagnosis of CAH depends on the demonstration of inadequate production of these hormones, in the presence of accumulation of which concentrations of precursor hormones. The most common form of CAH is the deficiency of 21-beta hydroxylase. The phenotype depends on the degree or type of gene deletion or mutation and the resultant deficiency of the steroidogenic enzyme. As mentioned, CAH is autosomal recessive, so 2 copies of an abnormal gene are required for disease to occur, and not all mutations and partial deletions result in disease. Disorders of CAH are commonly categorized by the deficiency of enzymes as follows: 21-beta hydroxylase deficiency, 11-beta hydroxylase deficiency, 3-beta hydroxysteroid dehydrogenase deficiency, and 17-alpha hydroxylase deficiency, in which the gene affected are as follows as well: CYP21A2, CYP11B1GF, 3-beta HSD, and CYP17. In any case of this disorder, it lowers the production of cortisol. Cortisol being a negative feedback to the production of adrenocorticotropic hormone, or ACTH, which stimulates the adrenal glands, affect the adrenal gland to try and produce more cortisol. The production of more cortisol still fails, and thereby causing hyperplasia on adrenal cells. The overstimulation of adrenal glands to produce hormones not only affect the cells, but also cause imbalance that manifests the patient's sexual development. The landmark of CAH are salt wasting along with hypotension and virilization. In salt wasting, the loss or decrease in aldosterone cascades to the loss of sodium in the body. Then dehydration due to inability to retain water, as well as hyperkalemia, as opposed to loss of sodium. This in turn leads to hypotension. In virilization, the increase in androgens, mostly in females, leads to ambiguous female genitalia, as well as precocious puberty with similarity to the male development. As said in the introduction, the diagnosis of CAH is dependent on the demonstration of inadequate production. So in 21-beta hydroxylase deficiency, the lab findings are usually high serum concentration of 17-hydroxyprogesterone. It is usually more than 1000 nanogram per deciliter. High concentration of urinary pregnenolone and elevated 24-hour urinary 17-ketosteroid levels. In 11-beta hydroxylase deficiency, it includes excess serum concentrations of 11-deoxycortisol and deoxycorticosterone and elevated ratio of 24 hours urinary tetrahydrocompound S, and as well as elevated 24 hours urinary 17-ketosteroid levels, same as 21-beta hydroxylase deficiency. In 3-beta hydroxysteroid dehydrogenase deficiency, abnormal ratio of 17-hydroxypregnenolone to 17-hydroxyprogesterone, and abnormal ratio of dehydroepiandrosterone to androstenedione. The imaging studies of CAH includes CT scanning of the adrenal gland and sonography such as pelvic ultrasonography and urogenetography, and to the extreme is bone age study. Other tests may also be helpful, such as genetic testing and newborn screening for 21-hydroxylase deficiency. Mostly management of CAH are on the patient's electrolyte status, such as if the patient has hyponatremia, you treat the hyponatremia, or if the patient has hyperkalemia, you treat the hyperkalemia. In other words, maintenance of the patient is done while diagnosis is being established. In surgical care, infants with ambiguous genitalia require surgical evaluation and, if needed, plans for corrective surgery. To see some cases of this condition, please check the description below. Thanks for watching.